Hi, in today's episode on Fast Intelligent Care, we will continue to talk about single-handed care. In our previous episode, we talked about what is single-handed care. In today's episode, we're focusing on the assessment. So how do I assess my client's suitability for single-handed care? Now, the very important focus of our single-handed care approach is that it has to be risk-based. So we need to do a very thorough risk assessment. Now, there's different ways we can do this. We do have the PEO model, person, environment, occupation, and then we have TILE. So this is task, individual, load, and environment. So very similar tools. A lot of these are integrated together to do your proper risk assessment. So if we look at TILE and we're doing our risk assessment, we are looking at what is the task involved. So when we're doing any manual handling, is there any bending? Is there lifting, pushing, pulling? Do we have any repetitive handling? How much rest time do we have in between specific tasks? And is there maybe any twisting of my trunk? So anything that could be damaging to the body or that could be straining to the body. This is what we'll look at with our task analysis. Then we look at our individual. What risks do we have with the individual? And here the individual is the caregiver or carer or family member who is doing the manual handling task. So we're looking at their own physical abilities, their height, if there's any limitations in their physical abilities. So it could be that they have health problems as well. It could be that they don't feel confident to do manual handling. So we're looking at their experience level, their confidence, the training that they've actually received. So we need to identify if there's any risk involved in terms of our employee or caregiver capabilities. And then we look at the load. When we look at the load, we're looking at the individual that is being lifted or being transferred or where we're who we are assisting with any manual handling. So when we look at our load or client or individual, we're looking at if they have any physical, cognitive, behavioral factors that could make this task or this manual handling task dangerous or potentially increase our risk. So this could be that the client has poor balance, they have unpredictable behavior, they might have joint stiffness or anxiety, they maybe are resistant to using equipment. So that's something we need to know, that they actually consent to using equipment. And we also want to be aware of sensory processing difficulties. If it's a plus size user, that complicates manual handling. And a lot of times with your plus size clients, it's more likely that you will have more than one support worker. But single-handed care is not always just about going from 2 to 1. Single-handed care, like I said earlier in our previous episode, is optimized or proportionate care. So single-handed care approach could also be, in terms of a plus-size client, going from 4 support workers to 3, or from 3 support workers to just 2. It's not necessarily always going from 2 to 1. It just means that we're making sure that we're not just relying on the number of supports. We are focusing on how do we eliminate or reduce risk. That is what the focus is on, not on support ratios. So it's about the reasoning, the clinical reasoning, rather than the number of supports. After we've looked at the task, the individual, and the load, we now want to look at what is the environment that we're doing the manual handling in. So are there any space constraints that could make it difficult to go over into single-handed care, or that just increases the risk? So this could be something like having a very small bedroom and having the bed against the wall, which will make it very difficult for us to be able to provide proper support to this client. Or it could increase risk because you might have one caregiver just on one side of the bed and they're having to bend over and stoop a bit more to be able to, let's say, apply a sling. And then we're looking at if there's any variations in floor levels or uneven flooring, limited access through doorways. It could be that there's poor lighting, poor ventilation. All these things could pose a risk to the caregiver as well as the client. And that could make your manual handling more challenging and might then require 2 people. So just as a quick example of a client that we can unpack with the tile approach is we have someone that is being transferred out of bed with a mobile hoist to get into their wheelchair. A sling application is going to be within the bed. We are going to have to reach over to get the sling supports underneath their legs. We are going to have to potentially roll them to get the sling behind them. Is there a way for us to eliminate some of the tasks? Is there anything that doesn't need to be done or that can rather be done with equipment? So can I rather have something like a slide sheet or an alternative sling application method instead of having a second person? Or can I look at if my client has the capabilities, let's say they do have some upper limb function, they can pull themselves forward if they're seated, or they can hold onto a grab rail while the sling's being applied instead of having a second person hold them into sideline. So we're, in this case, trying to maximize how much the client's also participating with the transfer. And then looking at the environment, do we have access around the bed on both sides so that the one support or one carer can actually go around both sides and assist the client instead of having to reach over to get the sling leg supports underneath their legs. So let's say we do have two people, we do have this reaching over, we do have having to lift up legs that are maybe heavy, we have a client that maybe can't assist with the side rolling or can't assist with leaning forward to get the sling behind their back. These are things that are going to reduce our likelihood of being able to do single-handed care, but we do need to assess the risks and still see if we can, as much as possible, eliminate any manual handling tasks with equipment, even if we are going to stay with double-handed care. So we can use something called the risk assessment matrix, where you look at the probability of something occurring and what is the consequence if that thing occurs. So with the risk assessment matrix, we have kind of like a traffic light system. So we have green, yellow, red as our categories. So it's low, medium, and high severity of risk. And then once we know the severity of risk for each of those, we're now going to go through a decision-making flowchart where we look at what is it that they're having difficulty with. So let's say the difficulty is with the rolling and maintaining that sideline position. Is this because of a physical ability not to do that? Is it because there's anxiety, or it could be that they're distressed, or is it because they are a plus size person? And then this will lead us to do further unpacking. So looking at how can we maybe minimize the anxiety or minimize them being distressed, looking at our approach or the environment. If it's because of a physical ability not to do it, can we use equipment then? So can we use a wedge to keep them in sideline instead of having a second person keep them in sideline? If it's a plus size person, maybe we're going to need we're going to have to grade our approach to something higher. So maybe we need a tilting mattress or tilting bed to get them into sideline and keep them in sideline. And then once we've determined that, we need to look at, can the environment accommodate this equipment? So let's say we have decided that we do actually need to turn someone using a slide sheet with handles, and that is going to help pull them into a turn. Can we then use a ceiling track or gantry hoist that we attach to these handles and pull them into a sideline? Does our environment allow for that equipment? So do we have floor space for a gantry, or do we have a reinforced ceiling or high enough ceiling to be able to do a ceiling hoist? And then we decide how many caregivers do we now need. Another way that we could look at this assessment is by identifying the roles of, if we do have two carers in place, what is each carer doing? We're looking at what the individual can do. So what is the client able to do? So first, let's start with, what is the client able to do? What is their strengths, their abilities? What can they assist with? So can they operate the handset? Can they lift up their leg? Can they hold on to a grab rail? Then what is the role of the first handler? What part of the activity is the first handler supposed to be doing. So are they maybe the one operating the bed? Are they the one that is applying the sling? Are they the one that is moving the hoist? Then we have the second handler. What is the second handler doing? What is their role? So are they maybe lifting up the leg to put the sling underneath? Are they attaching the loops to the spreader bar? And then we ask, can the second handler's role be done by the first handler? So let's say we said, for example, the second handler was the one that was keeping the person inside lying. So they were actually holding them inside lying while the first handler was applying the sling. Can the second handler's job be replaced by maybe that turning slide chute, or by wedges to keep them inside lying? Or could we change the actual sling application method by using a profiling bed and actually getting them into a seated position instead? And then we can also possibly eliminate, if rolling is the issue, we can eliminate that task altogether. So remember the questions, look at what the individual can do, look at what the first and second handler are doing. Can the second handler's job be done by the first handler? And if it can't be done, or some of the things can't be done by the first handler, can some of the roles or tasks of the second handler be done by equipment? Once we've decided that we are going to potentially implement single-handed care, we need to do it on a short trial basis. So we're making sure that we get the equipment in place, and now we're training our staff or caregivers to be able to do single-handed care. And then we are making sure that we are keeping record of how many staff are trained. We're potentially looking at their confidence, so level of confidence with actually using the equipment and doing the techniques. We are recording any incidents, any near misses, any accidents with this manual handling task. And then we are also looking at the amount of effort that these carers are actually exerting. So you could use the Borg perceived exertion scale. This is a way that you can see how much physical exertion is required to do the task, and you can actually compare that to how the task was initially being done and see if those scores have improved or if it has gotten worse. So are we actually now requiring more physical effort from our caregiver with doing single-handed care? We're looking at breathlessness as well. And then we also want to make sure that we're continuously doing risk assessments. So if we are changing the task, we need to make sure that we're covering that in our risk assessment as well. But once we do have we've seen that we now have a positive outcome from the short trial, we can then completely switch over or integrate our single-handed care approach. And we need to know that there might be cases where we might need to go back to double-handed care. So single-handed care might not always be suitable. So maybe it was successful when you trialed it and it's worked for a while, but now the client's health has declined. Maybe they got an infection, their blood pressure has changed. Maybe their mobility or muscle strength has decreased, so they're not weight bearing as much as they used to. They're not able to assist with the task as much as they used to. Maybe cognition has declined, or there's maybe behaviors that weren't previously there. Or it could be something that's temporary, a temporary condition like a chest infection or dehydration or UTI that is actually affecting the client's ability to participate. And that means that maybe we need to review our handling plan or our care plan, and we need to maybe potentially, even if it's short term, go back to double-handed care until we do deem it again safe and appropriate to go back to single-handed care. So the overall focus when it comes to assessment with single-handed care is that it has to be a thorough risk assessment, looking at all aspects, so environment, the person, the caregiver, and the task itself. We're looking at the roles of each person participating. We're looking at what can be eliminated, what can we have the client do instead, what can we have equipment for, and reviewing that and making sure that we are only implementing it if the review is successful. So that was our episode on assessing your suitability for single-handed care. if you want to know more about single-handed care, register for our app where we have a recording of a webinar, and there's also more info on our website. Look at any CPD events coming up, upcoming webinars, as well as blogs, and stay tuned for our next episode, which will come out on Tuesday. Thank you, and we'll see you next time on Fast Intelligent Care.